If you take a small pill every morning for blood pressure but still experience exhaustion, midsection weight gain, or difficulty climbing stairs without feeling winded, there is a real chance your doctor has you on a beta blocker. Current science reveals a reality that many physicians have not yet integrated into their practice, that medication may actually be working against your health. I am Dr. Thomas, and this channel exists to bring you the latest evidence-based research on senior health, simplified for adults over 60. If you have not subscribed yet, please do so now, as today's topic could fundamentally change your next medical appointment. Let's examine beta blockers. You likely recognize them by brand names like Toprol, Lipressor, or Tenormin, or generics such as metoprolol and atenolol. These have been prescribed for hypertension for over 5 decades, with doctors issuing tens of millions of prescriptions annually. They are inexpensive, familiar, and were long considered the gold standard for treating high blood pressure. However, the problem is that research has evolved. For many seniors with uncomplicated hypertension, beta blockers are no longer the optimal choice and may be making several things worse simultaneously. To understand why, we must look at how a beta blocker functions. Your heart has receptors that act like locks on a door, while adrenaline serves as the key. When they connect, your heart beats faster and more forcefully. Beta blockers occupy those locks so adrenaline cannot enter, slowing your heart rate and reducing the force of each contraction to lower blood pressure. This is logical and life-saving for specific conditions, such as recovering from a heart attack, managing heart failure, or treating dangerous heart rhythms. We are not questioning their necessity in those cases. However, for standard high blood pressure in otherwise healthy seniors, the evidence has shifted. The turning point was the ASCOT trial, Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet. This study followed over 19,000 hypertensive patients, comparing those on a beta blocker and diuretic against those using a calcium channel blocker and an ACE inhibitor. The trial ended early because the results were definitive. The beta blocker group experienced significantly more strokes, heart attacks, and new diabetes diagnoses. The calcium channel blocker group saw 23% fewer major cardiovascular events, a massive difference. Following these findings, the UK's National Institute for Health and Care Excellence formally removed beta blockers from their recommended first-line treatments for hypertension. They are no longer the preferred choice in British guidelines. Despite this, millions of Americans remain on them as their primary medication, often because it was prescribed years ago and never reassessed. Please comment below. Are you currently taking metoprolol, atenolol, or another beta blocker for blood pressure? Simply answer yes or no, so I can see how many of you are affected by this. Now, let's explore the specific ways these medications may be counterproductive for those over 60. The first issue is fatigue and exercise intolerance. When you block adrenaline receptors, you cap how high your heart rate can rise. While a younger person at a desk might not notice this ceiling, a 65-year-old trying to walk the neighborhood or keep up with grandchildren will hit a wall much sooner. You feel winded faster and your legs feel heavy because exercise feels disproportionately difficult. This creates a cycle. The medication makes activity harder, and less activity keeps your blood pressure elevated anyway. Consider Harold, a 71-year-old patient who reported such profound fatigue that he stopped his evening walks entirely. He had taken atenolol for 3 years, during which he gained 14 pounds, and his blood sugar reached pre-diabetic levels. His previous doctor attributed this to aging, but the clinical picture cleared once we reviewed his medication against current evidence. The second major concern is metabolic damage. Beta blockers are documented to increase insulin resistance, raise triglycerides, and lower HDL, good cholesterol. A meta-analysis in the Journal of the American College of Cardiology found that patients on beta blockers had a 22% higher risk of developing type 2 diabetes compared to those on other antihypertensives. For seniors managing blood sugar or in a pre-diabetic range, this is a significant risk added by a medication that isn't even outperforming its alternatives. What is truly surprising is that while beta blockers often lower the numbers on a blood pressure cuff, the underlying metabolic disruption and cardiovascular outcomes may still be eroding your quality of life. The third issue is the risk of falling, which is critically underappreciated in older adults. Beta blockers can cause orthostatic hypotension, a sudden drop in blood pressure when standing up from a sitting or lying position. That brief dizzy spell when rising from a chair is dangerous for a 73-year-old. It is a potential fracture waiting to happen. Hip fractures in seniors over 70 have a 1-year mortality rate approaching 30%. A medication-induced fall is a serious event. Before discussing better options, I must be absolutely clear. Never stop taking a beta blocker on your own without medical supervision. Abruptly stopping can cause a dangerous rebound effect, resulting in rapid spikes in heart rate and blood pressure, or even a heart attack. Any transition away from these medications must be supervised by a physician and conducted gradually over several weeks. I am providing information and questions for your doctor, not permission to make changes to your medicine cabinet yourself. What does the evidence suggest as better alternatives for seniors with uncomplicated hypertension? 2 medication classes stand out. First are calcium channel blockers, like amlodipine. The ASCOT data strongly favored this class over beta blockers because they do not carry the same metabolic risks or limit exercise capacity similarly. Research in the British Medical Journal confirmed amlodipine is associated with a significantly lower stroke risk than atenolol in elderly patients. The second strong alternative includes ACE inhibitors and ARBs, angiotensin receptor blockers. Medications like lisinopril, ramipril, losartan, and olmesartan show consistent benefits for seniors, offering kidney protection and better outcomes for those with diabetes, along with a lower fall risk. While ACE inhibitors can cause a dry cough in 10–15% of patients, an ARB typically provides similar benefits without that side effect. Dorothy, a 74-year-old patient, transitioned from a beta blocker to amlodipine and losartan over 8 weeks. Within 3 months, her blood sugar normalized, she lost 7 pounds without dieting, and she felt like herself again. Here is exactly what you should do with this information. First, identify if you are taking a beta blocker specifically for hypertension, rather than a diagnosed heart rhythm issue, post-heart attack management, or heart failure. Look for names like metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. Second, prepare 3 questions for your next appointment. 1. Was this prescribed specifically for hypertension, and does that still align with current evidence-based guidelines? 2. Have we recently evaluated my fasting insulin and triglycerides? 3. Would I be a candidate for transitioning to a calcium channel blocker or an ARB? Third, request a formal medication review if you have been on the same treatment for more than 2 or 3 years. You are entitled to an update if your care is based on outdated standards. Fourth, if a transition is recommended, confirm a tapering schedule. A responsible physician will reduce the dosage gradually over 4 to 8 weeks. Fifth, start tracking your data. Record your morning blood pressure, energy levels on a scale of 1 to 10, and blood sugar daily. This gives your physician concrete information to work with. One final clarification. There are absolutely patients for whom beta blockers remain the correct medication. If you have coronary artery disease, a history of heart attack, heart failure, or certain arrhythmias like atrial fibrillation, the clinical evidence supporting beta blockers is solid. Our discussion today applies specifically to seniors whose only diagnosis is hypertension without an accompanying cardiac condition. If that describes your situation, this conversation with your doctor is essential. If your medication is leaving you exhausted and your health markers are trending poorly, you now have the research and the language to walk into that appointment differently. You deserve a treatment plan built on current evidence, not decades-old habits. Comment, "Reviewing mine," if you plan to discuss this with your doctor, and share your current medication below. I read every response and your questions help shape future videos. Please share this with loved ones today. I'm Dr. Thomas. Subscribe if you haven't already, because next week we're covering the silent mineral deficiency that makes blood pressure medications significantly less effective. I'll see you there. Take good care of yourselves.